You wake at 3:17 a.m., again drenched, heart pounding, and by morning you barely recognize the body you've lived in for decades. You're doing the same meals, the same walks, the same discipline that worked at 35, and your middle keeps changing while someone tells you, it's just stress, it's just aging. Look, that sentence is where the silence starts. Estradiol can drop about 95% after menopause. About 80% of OBGYN residency training still lacks solid menopause preparation. Close to 75% of symptomatic women go untreated, and 1 in 5 women report being dismissed in the exam room. So tell me, how were you supposed to figure this out alone? Drop a comment and tell me where you're watching from, because I want to know how far this conversation is reaching. If you were told you're not a hormone candidate, so your only option is to suffer through this naturally, I'll tell you honestly, that is the lie we have to confront right now. Stay with me until the end, because the key piece most women never get is the mechanism. Why 2 women with the same symptoms contrive the same natural plan and get opposite results. When you understand that, everything changes in how you see your body, and you stop carrying blame that was never yours. You wake at 3:17 a.m., soaked, heart racing, then stand in the morning light wondering why your own body feels like a stranger. You keep the same meals, the same walks, the same discipline that worked in your 30s, and your middle still changes while someone tells you, it's just stress, it's just aging. Look, that is where the silence starts. After menopause, estradiol can drop by about 95%. Around 80% of OBGYN residencies still lack solid menopause training. Close to 75% of symptomatic women go untreated, and 1 in 5 women reports being dismissed in the exam room. Drop a comment and tell me where you're watching from, because I want to know how far this conversation is reaching. If you were told you are not a hormone candidate and your only option is to endure this, I'll tell you honestly, that is not the full clinical truth. The silence ends in this row. Stay with me, because the real mechanism, the one that explains why 2 women with the same symptoms can follow the same natural plan and get opposite outcomes, is still ahead, and what you are about to hear explains more than you ever imagined. Your mother was told to push through it quietly, and your grandmother didn't even have words for it, just a drawer full of handkerchiefs and a tight smile at breakfast. Then, in 1966, medicine swung hard the other way and called menopause a defect to be fixed, not a transition to be understood. I'm telling you this because the silence was inherited long before you walked into your first exam room. The language was wrong at the start, and when language is wrong, treatment follows the wrong road. And that road is exactly what we still need to untangle. Then came the WHI shock in 2002, and the message that reached women was fear, not nuance. In one major cohort, menopause hormone therapy starts fell from 8.6% to 2.8% almost overnight in clinical culture terms, and nobody explained age windows or risk stratification in plain language. From 2002 to 2020, I watched women get pushed into a false choice, untreated symptoms, or expensive natural promises with no mechanism behind them. If you're wondering why the same advice keeps failing you, hold that question, because the missing piece is not effort, it is targeting. And the training pipeline never truly recovered. Only about 31.3% of U.S. OBGYN residency programs reported a formal menopause curriculum, and many doctors came out with a few scattered lectures instead of a working framework for real patients. Add short visits, insurance denials, and a culture that erased women over 50, and you get the same sentence in different voices. This is normal. Live with it. That is how your symptoms were framed as personal weakness. What happens next, when this goes untreated, is where the real cost begins. Here are the players, and I need you to see them clearly. Training systems taught smart clinicians how to rule out crisis, but not how to map menopause physiology in real time. Thermoregulation crashes, cortisol spikes after fragmented sleep, and symptom clusters that cross brain, bone, bladder, and metabolism. After the WHI era, the public story flattened into fear, so individualized risk discussion disappeared before it ever reached your exam room. Then, short appointments rewarded reassurance over investigation. That is how perimenopausal and postmenopausal women were left with polite dismissal instead of mechanism-based care. When medicine left ambiguity, the wellness market sold certainty, and the money tells the story. Projections climb from about $18.31 billion to $29.19 billion within one forecast window. Your mother was told to endure quietly, so you inherited that silence like an heirloom and walked into midlife without a map. The women paying the price are the ones in their 50s and beyond, the ones late in perimenopause, the ones years past their final period, still carrying sleep debt, visceral fat gain, mood volatility, and untreated genitourinary symptoms. Stay with me, because the next layer is the mechanism that predicts who improves first without hormones. Look, the first thing hidden from you is receptor geography. Estrogen is not a period hormone, it is a signaling system across more than 400 tissues. So when ovarian output drops, your skin, bladder, urethra, vagina, blood vessels, joints, and brain all receive weaker instructions at the same time. More than half of postmenopausal women develop genitourinary syndrome, yet dryness, pain, urgency, and recurrent UTIs are still brushed off as inevitable. That is why your body can feel unfamiliar from head to pelvis in one season of life. And the brain layer I am about to show you is where this becomes undeniable. The second layer is neurological, and this is where you start wondering if you are losing yourself. In vasomotor research, the thermoneutral zone, that is normally about 0.4 degrees Celsius, can collapse to almost zero, so a tiny heat shift sets off a full alarm, pounding heart, sweat, panic, then mental fog the next day. It can look like a psychiatric disorder when it is a hormone-linked brain signal problem. I remember one winter dawn at my kitchen sink, feet on cold tile, chest buzzing like a dozen phones on vibrate. In 30 years of practice, I have seen this exact pattern thousands of times. Now let's talk about why this rewires metabolism. Here is the metabolic layer most women never get. When sleep is broken night after night, your HPA axis stops pulsing cleanly and stays on guard, and that is often mislabeled as just stress. In a controlled 5-night menopause model, bedtime cortisol rose 27%, and the cortisol awakening response fell 57% after fragmented sleep. That pattern pushes insulin resistance and visceral fat storage even when your habits have not changed. Then add one more blind spot. Testosterone in women is almost never tested when libido, muscle tone, and motivation drop. These layers compound. They do not cancel, and the clinical reality of that is what will finally make your symptoms make sense. Look, let me explain what is actually happening in your body. Once your cycles stop for 12 straight months, your ovaries are not giving the same feedback, so your pituitary pushes harder, and FSH commonly climbs above 25 IU per liter. In late transition patterns, we often see annual FSH values crossing 34, and that is when bone turnover and sleep disruption start showing up together, not separately. So this is not one symptom at a time. It is one network losing coordination. And if that network is the issue, why would generic advice ever be enough? Perimenopause is not a quick detour. For many women, it runs about 4 to 8 years, and frequent vasomotor symptoms have a median duration of 7.4 years, with persistence around 4.5 years after the final menstrual period. Now add sleep architecture. Your brain needs roughly 90-minute cycles to restore mood, glucose control, and memory, and night sweats keep slicing those cycles apart. That is why sleep disturbance is reported in roughly 40 to 60% of women in this phase. So if your nights keep breaking, what do you think your metabolism does by morning? I had a patient last month, I'll call her Sarah, and I can still see her hands gripping the tissue on my desk. She told me, "I feel like I am disappearing." She had been told to eat less, walk more, and stop worrying. I showed her the mechanism. During the transition, insulin resistance can rise about 8.7% per year, then continue around 4.2% per year after, even before fasting glucose looks alarming. She went quiet, then said, "So I'm not doing this to myself." That recognition matters, because the next question is where that metabolic pressure gets stored. And this is where your waistline story becomes clinical, not moral. In Swan Heart, visceral fat rose about 8.2% per year in the window just before the final period and 5.8% per year afterward. A 20% higher visceral fat burden was linked to about a 2.0% higher internal carotid wall thickness marker. So when you hear same habits, same body, it sounds reasonable, but your physiology is running a different program now, especially after broken sleep and stress signaling. If that is happening in fat and vessels, what is happening in bone at the same time? Bone loss does not wait politely for old age. It accelerates around menopause, often starting near 1 year before the final period, and in prospective cohorts, the early phase has shown losses around 2.4% per year, then slowing towards 0.4% per year later. Other endocrine data show that cumulative loss during this window can reach up to 1/5 of bone mass in some women. So no, just push through is not neutral advice. It has a measurable cost. And once you see that cost clearly, how could we keep calling this normal aging care? Here is the turning point, and it is brutally clear. Your ovarian signaling stays low, your grain's heat alarm gets jumpy, sleep keeps breaking, and your stress system stops resetting overnight. So even when you eat carefully, train consistently, and do every healthy thing, your body keeps storing threat instead of releasing it. You wake up wired and tired, then blame yourself by lunch. I need you to hear this exactly as I say it. You are not crazy. You are not alone. And if this is the cascade, why were you handed vague tips instead of a mechanism? The hard realization comes next, and yes, it stings. Your body is not betraying you. It has been managed with the wrong map. Someone decided this conversation was optional, and you paid for that silence with confidence, sleep, and years of self-doubt. I can feel the quiet anger in the room when this lands, because the old story collapses in real time. That is not aging. That is a hormone shift nobody explained to you. So the real question now is not whether your symptoms are real, it is what this silence costs if nothing changes. If you keep accepting silence, the first 1 to 3 years usually look like this. The flashes keep coming, the night sweats keep cutting your sleep in half, and your mornings start with that wired, hollow feeling you cannot explain to anyone. Libido drops, patience gets thin, and even good relationships feel strained by things that were never a problem before. Then self-blame grows, quietly, month by month, because you were told this was about willpower. It is not. It is untreated physiology. And if this is the short window, what do you think the middle window does? From 3 to 10 years, the cost gets less visible, but more structural. Bone remodeling stays tilted toward loss, so a DEXA score that once sat near minus 1.0 can drift toward minus 2.5 before anyone takes your symptoms seriously. At the same time, vascular tone changes, LDL handling gets less favorable, and your old cardiometabolic margin narrows. Genitourinary syndrome does not usually self-correct. It is typically chronic and progressive without treatment. So dryness, urgency, pain, recurrent infections, they become a pattern, not a phase. If those systems are all shifting together, why are you still being managed symptom by symptom? Then the 10 to 30-year horizon appears, and this is where silence becomes life-altering. About 1 in 2 women over age 50 will experience an osteoporosis-related fracture if bone health is not protected. Heart disease remains the leading killer of women in the United States, and in 2023, it accounted for 304,970 female deaths. Cognitive confidence can erode when years of sleep disruption, metabolic strain, and untreated symptoms stack on top of each other. You are not doomed, not even close, but you are exposed if nothing changes. So when do we stop calling this normal and start calling it preventable? And while those long timelines are building, the emotional cost is already here today. Anxiety symptoms are reported by about 70% of women in this transition in many cohorts, and depressive burden rises sharply, with studies showing perimenopausal risk elevation compared with premenopause. Shame takes root when you think this is your fault. Isolation follows when everyone around you says they are fine, so you stay quiet and perform normal while your brain feels wrapped in static. That is the part that breaks my heart in clinic. How many more years were you going to spend apologizing for biology? This is exactly why mechanism-matched, evidence-based, non-hormonal care matters when hormones are not an option. Not because you are fragile, because time compounds untreated patterns. The longer the silence runs, the harder it is to unwind sleep, mood, metabolic, bone, bladder, and relationship consequences all at once. Drop a comment and tell me which of these you were told was just stress or just aging, because I want you to see how many women are carrying the same story in private. This is not personal failure. This is inherited silence with measurable physical cost. If nothing changes, the first 1 to 3 years usually feel like a slow theft. You keep waking in the night, then trying to function on broken sleep like nothing happened. Your patience gets thinner, your confidence gets quieter, and by afternoon you are running on adrenaline and guilt. You start wondering why your relationships feel harder when you are trying so hard to keep everything steady. Look, this is where many women get blamed for being too sensitive when the real driver is untreated physiology. Then, in the 3 to 10 year window, the consequences get less dramatic on the surface and more serious underneath. Bone loss can accelerate during and after the transition, sometimes up to about 20%, while nobody explains why your joints ache and your recovery feels different. Cardiometabolic risk starts to shift in ways you cannot see in the mirror. Genitourinary symptoms often become chronic if ignored. So yes, you can still look fine to everyone else while your body is quietly paying interest on years of dismissal. In the 10 to 30-year range, the silence becomes expensive. About 1 in 2 women over 50 will have an osteoporosis-related fracture, and that is not a small statistic. That is independence on the line. Cardiovascular disease remains the leading cause of death for women in the U.S., and that risk conversation is still missing in too many menopause visits. This is why I get so direct about timing. Not to scare you, to make sure you do not lose a decade believing this is just how life has to be now. And while those long-term risks build, the emotional damage is already happening today. You begin to edit yourself in real time. Fewer plans, less spontaneity, less closeness, less trust in your own mind. You stop bringing symptoms up because you are tired of hearing stress and normal aging. I have watched strong, capable women start talking about themselves like they are fragile when they are not fragile at all. They are exhausted from carrying symptoms without a map and from apologizing for things that were never character flaws. So I want you to answer this out loud, or in the comments if you can, share below, which of these consequences are you living right now, and which one were you told was just stress or just aging? I read these because patterns matter, and because seeing other women name the same reality breaks isolation fast. The moment you name what is happening, you stop negotiating with denial and start asking for mechanism-based care. This is not personal failure. This is inherited silence with measurable physical cost. Tomorrow morning, walk in with a symptom map, not an apology. Doctor, have you completed any continuing education in menopause management in the last 5 years? Then, I'd like to request a comprehensive hormone panel including estradiol, progesterone, testosterone, and thyroid, not just a standard TSH. If weight changed despite stable habits, add, please include fasting insulin. If your stage is unclear, ask for FSH trend context. And if you feel brushed off, use this line. I understand my labs may appear within standard range. I'm experiencing sleep disruption, hot flashes, and mood changes, and I'd like these investigated as potential hormonal causes, not dismissed as stress or aging. This is hard. You are asking a system that failed you to suddenly serve you. But now you have the language it responds to. Look for a menopause-certified clinician, not just a general listing. Check the Menopause Society directory, look for NAMS-based training history and credentials like MSCP or documented menopause-focused continuing education in current practice. If you are over 50, ask directly for a DEXA scan. If care is fragmented, ask for a non-hormonal plan by symptom cluster. You are not failing. You were never told the truth about what was happening to you. You are a woman with clinical clarity and practical tools to demand the care you deserve. The silence ends in this row, not because your symptoms magically disappear tonight, but because you can finally name the mechanism instead of blaming your character. So let this question stay with you after this ends. How many years were taken from you by the wrong map? And what changes the moment you stop accepting dismissal as care? Share your story below. I read every one, and tell me what you needed to hear today that you had never heard before in any exam room. In the next conversation, I will show you exactly how to find a menopause-trained clinician when someone says, "This is normal aging," and the 7 questions that reveal, fast, whether they can actually guide non-hormonal care by symptom cluster. That is the next layer we need to uncover, because access changes outcomes. Keep your symptom map with you. Bring your words, not apologies. Take care of yourself. I will see you in the next one. You carried this quietly for too long, and now you have language for what your body has been trying to say. So share your story below. I read everyone. Tell me in the comments what you needed to hear today that you had never heard before in any exam room. And if something finally clicked for you tonight, say that too, in your own words, because naming it is how you stop shrinking around it and start asking for care that matches what is actually happening. In the next conversation, I'll walk you through how to identify a truly menopause-trained clinician when you are told this is just aging, and the exact questions that expose whether you are being managed by habit or by mechanism. Keep your symptom map. Keep your voice steady. No more apologizing for biology. Take care of yourself. I will see you in the next one.